Yes. Well.
Hello. I'm on a Zoom COVID-19 information. Is that right? Yeah.
David, could you do the welcome so we crack on, please?
Okay, thank you very much. Can I welcome all of you? My name is David Weaver. I'm chair of CORE, which is the Coalition of Racial Equality Organisations, and we're really proud to be hosting this event. We all know that COVID-19 has laid bare the inequalities that we already knew existed in our society, and it has meant that Black communities, African, Caribbean and Asian communities in this country has been hit disproportionately. And if we had time, we would speak in a lot of detail about some of the reasons for that and some of the psychological impact that is having on our communities and the impact of that in terms of depression and anxiety and trauma. And we all know that that's what's happening in our communities. But really our focus today is on the issue of the low uptake of COVID-19 vaccines. And we want to give an opportunity for you to really engage in conversation. We have an eminent array of clinicians and doctors from our communities and specialists, and also a government minister here and other advisors who will be finding the opportunity really just to engage with you. But this meeting is really about you and the opportunity for you to really speak openly about your concerns. So do engage, use the chat function. And we really will want to ensure that the questions that you are wanting to ask and the points that you're wanting to lay bare are engaged with and answered and explored in this meeting. This is a really, really important issue. And it's really important for you to make the right choice and to get the facts. And that's what this meeting is all about. It's a state of emergency, really. And that's why, I'm proud as the chair of CORE, along with partner organizations within CORE and others, and more importantly, members of communities, to really engage in this conversation. It's such an important one. So I'm going to stop at this point and pass on to Conley Ololade, who's the director of Voice4Change England, who will just give a few more opening remarks and set a little bit of the context for this really important conversation.
Good evening, everyone. It's great that there are so many people online tonight involved in this important discussion. CORE, as David has said, is a coalition of race equality organizations that was formed to develop policy in the UK and to also campaign against institutionalized racism. Interestingly enough, at the very start of this pandemic, we picked up very early on about the disproportionate impact of COVID on our communities. We could see potentially in the way that our community was set up, in terms of the areas where people worked, in terms of the type of situations that they faced, in terms of health issues, that it was going to have a disproportionate impact. We wrote letters to government. We also campaigned and within our communities to raise awareness about our position. And I think some of that definitely landed with government and with the charity sector. Tonight, we're really focused, though, as David has indicated, on the question of the low take-up within our community and to discuss some of the arguments around that. But more importantly, as we've found in the last 3 days, it's not just a skepticism that comes from our communities. 11 countries, I believe now, predominantly European, have expressed views around the AstraZeneca vaccine and have suspended its use. I think that message, when it's sent out to the people that we're trying to persuade, makes our lives all the more difficult in terms of reinforcing their own doubts. And if that wasn't enough, we know that there are issues in post-lockdown in relation to the question of vaccination passports and how that raises new challenges in terms of discrimination that we are trying to just work out and understand. So certainly tonight we have an opportunity. We have a fantastic lineup of experts. We also have the Minister in charge of vaccinations here. So ask your questions and listen to the speakers. And hopefully, if you're not persuaded yet to take the vaccine, by the end of tonight, you will be. And I'll leave it there. Thank you.
Good evening, everybody. Thank you so much for giving up your time. My name is Ngozi Ediosage. I'm a neonatologist and I'm working in Manchester. I'm also the medical lead for the Caribbean African Health Network. Now, over the past few days, we've all seen the news about the AstraZeneca. And as Kunle has said, that has made things a bit more difficult. But as a doctor, I know that I'm in an incredibly privileged position that made the decision to have the COVID vaccine relatively easy. And that's because I've been up close and personal. I've seen firsthand the impact that this pandemic is having on our lives. And whilst the headlines have mainly focused on the number of deaths, and I think rightly so, as doctors, we're seeing the secondary impacts of this on our patients. Now, the facts are that there are more than 100 people worldwide that have been affected by COVID. There have been more than 2 million deaths. And we know in the UK that it disproportionately affects ethnic minorities. But we are sensitive to hesitancy, and I feel it really should stop being stigmatized, and that your concerns cannot be minimized and they shouldn't be dismissed, and that's why we're here. We know that people who are hesitant can still be convinced of vaccine safety and efficacy, and more importantly, they are not anti-vaxxers. We've been listening for the past couple of days to the fact that the AstraZeneca vaccine has been withdrawn from a number of countries. So hesitancy is not just in our community, but we're here today to make sure that we give you facts and information. The other thing I want to say is that we know that GPs are trusted members of their communities because of the relationships they build over time. And we know that as Black and Asian doctors, that we're also trusted by our communities as well. And that's why we're here doing this event. Myself and all our colleagues here today are answering questions because, one, we've had the vaccine. None of us have been paid to be here, but we feel that it's really important for us to be here to give you some additional information. My colleagues range from GPs who have seen the long-term effects on patients who have been discharged from acute care, from intensive care, but they're still needing to be seen on a regular basis because they've got long-term effects of COVID. One of my colleagues here has worked in intensive care and can tell us about the first-hand effects he's seen in intensive care and how we feel about this. We have colleagues who are emergency doctors, a colleague who's a chest physician, a metabolic physician, and a nephrologist. We are tired of what we're seeing, and we really need to try and genuinely make a difference so that the devastation that we're seeing in our hospital comes to an end. And really, that's why we're giving our time to discuss and answer your questions today about the COVID vaccine. Now, one of the things that we have a chat box, and I'm just asking you to use that as much as you can so that we can answer a lot of your questions. We're probably not going to be able to answer all your questions today, but we'll answer as many as we can. And for those of you who are watching online and not on Zoom and can't use a chat function, please ask your questions as well, because our volunteers will put them here and we will try and answer them as we go along. So what I'm going to do now is to invite each of my colleagues to tell you about their experience about having the vaccine, why they had it, some of their personal experiences, and then after that, we'll go ahead and start answering your questions. So once again, thank you so much for being here and giving up your time this evening, because just as we feel it's important, I'm sure you feel it's important, and that's why you're here. So thank you very much. So I'm going to start off with asking Dr. Benita Kane, who's a chest physician from Manchester, to introduce herself and to talk about why she had the vaccine.
Thank you, Ngozi. Can you hear me okay?
I can hear you, Benita.
So I'm Benita Kane. I'm, as Ngozi's just said, a chest physician in Manchester, and I've spent the last year really at the forefront of the COVID-19 pandemic. And I think the reason I'm so passionate about this topic is because of those experiences. So I've witnessed and experienced that kind of relentless and devastating march of COVID-19. It's unselective. It'll affect anybody. It takes unmercilessly, and it's not just the families and friends of those who've died, but as Ngozi said, there are many people now living with the effects of having had severe COVID. They've survived ventilation. They now have long COVID, which is a really debilitating condition that's affecting people's mental health, their physical health, their livelihoods. I've got consultant colleagues who can't work anymore because their lives have been so impacted. And it's been really, really hard for everyone. I've actually personally lost a dearly loved colleague as well, and we know that we have lost too many members of our NHS family who have given their lives to look after others. And for me, it was very upsetting to hear that the people we know that this disproportionately affects our communities, and it's very upsetting to hear that those are also the communities who are most fearful of taking the vaccine. Like Ngozi said, I understand these concerns are valid, they are real, and I have seen firsthand a lot of the information that's circulating about the virus on social media, I am really not surprised that some people are worried and scared. I was quite alarmed reading some of the things myself. And you know, I'm really not here to tell people what to do, but I'm here because I want to make sure that people are making decisions armed with the right information. And I was lucky enough to have my COVID vaccine before Christmas. And in January, 2 colleagues in my office who I sit in very close proximity to, who hadn't had the vaccine, they came down with COVID and they were quite ill. So not hospitalized, but they were unwell, off work for a few weeks. But I was safe. And the wife of one of them also had been vaccinated in December, and she was safe. And now I'm really lucky enough to have had my 2nd dose, and I feel safe in work. I feel very fortunate that my 81-year-old dad has had the vaccine, but I won't relax until he's a few weeks clear of his 2nd dose. And most people I know in work, you know, 80% of our workforce has now been vaccinated. Most of them have had very mild symptoms. A couple have felt quite rough for a couple of days, but that's all. I had a bit of a sore arm. And, you know, for me, this vaccination program is so important. It paves a way out of this. It paves a way for us to get some semblance of normality back and to save more lives from being lost. And so I really hope that we can address some of those concerns this evening, and this is a useful event for everybody.
Thank you very much, Benita. Thank you so much. That was really helpful. I'm going to invite Dr. Vanessa Appiah to talk to us about why she had the vaccine and her experiences. Thank you, Vanessa.
Thank you so much. I'm a consultant in sexual health and HIV, but also within COVID, I was redeployed and working in ITU. And I think it's always really interesting when you listen to other colleagues talk about their experiences, because it resonates so much. And for me, COVID was just such a Russian, it is such a Russian roulette. You have people that will acquire it and are fine, minimal symptoms, and then those that you least expect suddenly have been doing well and suddenly deteriorate, and some of those people have died. I've lost colleagues, I've lost family members, but I think that it's just been a really painful reminder as well of all the inequalities in society as well, that has really driven me to be part of these conversations. And I want to say that the decision making is a journey. So for me, it was really clear that working where I was, seeing what I had seen, I was desperate to get the vaccine. And I'm always very honest about it. I got COVID before I got the vaccine. So I got COVID in December, and it was terrible. And I also, my parents were unwell, and watching and the anxiety of what could happen. I never want to go through that again. And I never want anyone that I know to go through that. And I think that has been one of the most powerful motivators for me in being part of these conversations. I think that the vaccine, as we recognize it, is key to us breaking the chain of COVID. It isn't the one and only thing, but it is a really essential element for us to say, right, we are going to be moving forward. And I emphasize always hands, face, space, and vaccine. And I just want to acknowledge those that are going through that journey of trying to work out if the vaccines are for them. I would say that us as clinicians of color, I don't take this privilege lightly to be here in front of you to advocate for something if I didn't believe in it, because I know we're here as trusted individuals within our communities. But as a clinician, as someone who's worked in the area, as someone that is part of our communities, I really do believe that vaccines are safe and effective, and I would really welcome the opportunity to speak to people more if they have any concerns. So that's really my guidance really about it.
Thank you so much, Vanessa. That's really helpful. I'm going to move on now to Professor Mahesh Nirmalan, who's an intensive care consultant.
Thank you very much indeed. Can you hear me?
Yes, we can hear you well.
Yeah. Hi, my name is Mahesh Nemalan, and I'm one of the intensive care consultants at Manchester Royal Infirmary. I think it's fair to say over the past year or so, I've seen disease and human suffering at in the extremes, people's experience of all people, all sizes, all shapes, all colors, all backgrounds. I could go into some of those individual stories, but I'm not going to do that because I don't want to be, emotionally make people make a decision one way or the other. So what I'm going to do is just to share some of my personal experience of what I did really. When I first heard about this about just over a year ago now, I knew that I was 59 years old. I was South Asian background, bit of pot belly, bad family histories. I ticked all the kind of boxes for a very high risk person. And I was working in intensive care, dealing with actual, very seriously ill COVID patients. So the pathway I took was to focus quite a bit on my well-being, my physical well-being, my emotional well-being, my psychological well-being, my spiritual well-being, because well-being is a package deal. And I did put quite a bit of effort into getting that holistic approach right. Secondly, I adhered to the public health guidelines that were available to me, the hand washing, the face masking, the social distancing in a very, very religious kind of way. And I think that has helped me. Thirdly, when the vaccines became available, I shared many of the concerns most people in this audience will have, many of my colleagues will have, because at the end of the day, it has come out very, very rapidly. So I did have my concerns. But nevertheless, decisions in life is always about balancing risks and benefits. And on that basis, I realized that the vaccine was the right approach to go, and I took the vaccine. And now I've taken both doses of the vaccine. I took the Pfizer vaccine because that was the one that was made available to us. And I have very, very minimal symptoms, and I've come through that. My wife yesterday went and took the AstraZeneca vaccine. She had a bit of sore arm and a bit of a flu-like feeling last night, but she's fine. She's gone out doing some shopping today. My son has again taken the vaccine. He works in intensive care in another city, and so we are feeling confident that hopefully we are seeing the light at the end of our tunnel. And I really wish most of the people who are here and the people who in the community that I work with will also see that light at the end of the tunnel very soon. I admit that there are fears, anxieties, but on risk-benefit analysis, I think going for the vaccine is the right thing, and it is safe by every account that we see available to us. Thank you.
Thank you very much, Mahesh. Thank you. That's really helpful. I'm going to hand over now to Mr. Yakubu Karagama, who's an ENT consultant at Guy's and St. Thomas's.
Hello, everyone, and thank you for your kind invitation to this very interesting meeting. As Ngozi introduced me over there at ENT consultant at Guy's and St. Thomas Hospital, and in particular, my subspecialty area is dealing with airway, voice, and swallow. So you can see where I'm going to be coming from. I've been heavily involved with looking after COVID patients, both in my clinic, in the theater, and I was one of the team that were doing the tracheostomy for patients that have been intubated. So during the first wave of the COVID pandemic, when we were not sure how to handle this group of patients that have come down with severe COVID, a lot of patients got intubated. And just 3 months after that, almost half of the patients that were intubated, after they got discharged, I began to see patients coming back to my clinic with complications. And these complications were from the treatment for the COVID infection itself, like the intubation, the tracheostomy. So what happened was the tube causes some scar on the vocal cords. And the complications that patients like that develop was loss of voice. So you can imagine if none of us here can speak, we won't be able to hold this meeting. So I've seen lots of young people that have lost their livelihood because after the COVID infection, they were treated, they got discharged, but their life has never been the same anymore. There are other group of patients that were sent home with tracheostomy. So a tracheostomy for people that are not medical is like having a hole in the front of your neck over here. So you won't be able to breathe through your nose and everything goes through there. I had patients that cannot eat or drink because their swallowing pipe has been blocked from scarring from the COVID infection. And such group of patients will have what we call gastrostomy tube. So this is like a tube that is plunging directly in front of your belly into the stomach, and everything that you eat or drink have to be mashed into like liquidy form, and you have a syringe and then push it through this gastrostomy tube. So these are some of the few things that make me be very, very serious and confident that if vaccine comes at that time, I will be the first one in front of the queue to have the vaccine. And luckily in my hospital, those first 2 weeks when the vaccine was introduced, a lot of us were able to get the vaccine simply because by evening time, some of the vaccines that were open, because people were not turning up in good time and they will have to throw these vaccines away, we were advised that if you want to take the risk, you can go and queue up in the evening to have the vaccine. So I went in there, queue up in the evening, 8 p.m., had the vaccine. So the first vaccine, I was fine. I went swimming 50 lengths the next morning, no problem at all. And then I had the second course of the vaccine, that's the Pfizer vaccine. And I felt tired the next day and had a couple of paracetamol. And that actually reassured me that, yeah, maybe something is happening in my system. So I feel much different now after the second vaccine. So why I've come to have the vaccine, those are the reasons, but also people have died from this vaccine, from this COVID infection. People have lost their livelihood. And I'm having the vaccine not just to protect myself, but to protect others. So this is one thing that people need to be aware, because some people say, well, maybe the risk of the vaccine may be higher than if I have COVID, I'm young, I don't have any health issues. But what about other people that you may transmit this? And also now we know the long COVID, whether you're young or old, whether you have any health issues, you can still develop long COVID. And by long COVID, it means you develop some symptoms 4 weeks up to months after the COVID infection has gone. And some of these symptoms can be very debilitating. There could be heart conditions, there could be mental health issues, there could be a respiratory problem. The whole list of them that we're still not there yet. We still don't even know how much this disease can affect us. So
thank you. Thank you very much. Yeah. I just want to give other people an opportunity to say why they had it, because I'd really like to get to the questions, but that was really interesting, Yakubu, because it's not just the infections themselves, it's about the long-term effects of it as well. Dr. Diana Sante is a GP. Diane, are you here? Diane, are you here?
Maybe she's muted.
Okay, can you unmute yourself, Diane? Okay, while you're trying to get unmuted, I'm going to move on to Dr. Sunil Daga, who's a nephrologist.
Hello, good evening. I'm a nephrologist and I practice at Leeds, and I'm also a medical advisor to a charity called South Asian Health Action. I'll share my own experience both as a consultant in kidney disease and also a family story. First, I think I've taken COVID personally. It's affected not only my professional life, but my personal life. My wife is an anesthetist and she works in intensive care. In the beginning, in the first wave, my 7-year-old daughter used to cry whether her mom will come back home alive. Every time she used to go to the work, she was scared that her mom is going to catch this infection and will die. And the reason is, I had a very good friend who I lost, who was younger than me, fitter than me, with no comorbidities. And then I have my patients who are absolute inspiration because they have one of the most dangerous and a chronic condition, kidney disease. There are many of my patients who are on machines such as dialysis to clear the toxins and to keep their life. And there are a number of patients who are waiting for a gift of life, a kidney transplantation. The reason I took personally as professionally is COVID, when it hit, we had to close all the transplantation program in the country. The gift of life that was available after somebody dies was suddenly wasted. And many, many people who had a hope of living back to normal that hope was taken away. There were family members who were prepared to donate a kidney as a living person, and they couldn't do that because all the programs were shut. All the resources went to look after very sick COVID patients. Perhaps many of you know, kidney disease is very common in BAME, so our ethnicity. And about 1 in 2, 1 in 3 patients are from that ethnicity. I try really hard to talk to my patients about the vaccine. And I'm really pleased that all my patients, whether they're BAME or white, they all had vaccine. It's about interacting, it's about talking to them. And I find, handling misinformation is important. Yes, some people will make personal choice and I respect. But in the poll that we did at the beginning, 20% of you are undecided. And that's what I think my task and my colleagues' task would be, is to get those undecided people towards taking the vaccine. I really cannot emphasize it is so important. There is no way out of this mess, I'm afraid. I know there are some genuine concerns, and I will be happy to take questions, particularly about vaccine efficacy in people who are immunosuppressed, who have cancer, or who have organ transplantation, because the studies did not look at that. And I'm personally involved in a study called Uptake study. So I'll be happy to take that question later on. Thank you.
Thank you very much. Thank you. And now I'm going to go to Dr. Patel, who's a metabolic medicine consultant.
Thank you very much. It's Dr. Prashant Patel. I'm also the associate professor at Leicester. I think the story was very similar to Dr. Daga's story. For me, my wife is a consultant in medicine, and in May she was diagnosed with COVID after covering the COVID ward, and she became quite unwell. And then with 2 children, I wasn't sure whether, and there were no medicines at the time as well. I wasn't sure what's going to happen to her and to the whole family. And obviously, luckily, after 6 weeks, she got better. And I think science came to the rescue. After that, many drugs were discovered, and in December, finally, vaccine came through. Honestly, at a personal level, I've never looked forward for anything in my life so much, as much as vaccine was. Having seen that the destruction of COVID disease caused at a very close level. And I think the earliest opportunity when we were eligible, we both took vaccine. There were like flu-like symptoms, yes, and for a day we took paracetamol, and then flu-like symptoms were controlled. I think the question here is, what are we comparing COVID vaccine against? We should not compare COVID vaccine against a normal life, which we're all having now, without any symptoms. We should compare COVID vaccine against COVID disease, and it's all the destruction it brings, including COVID, long COVID, death, financial destruction, and so on. So if you actually compare COVID, disease with the COVID vaccine, I think the choice is very easy. In fact, I was involved in a study where we looked at the healthcare professionals' uptake, and one of the questions was people were very willing to take contraceptions, and then even that caused lots of side effects, and where they can see the effects of contraceptions with the pregnancy and then good or bad effects from the unwanted pregnancy. But whereas here we compare it against the normalcy. So COVID vaccine cannot be compared with the normal life. COVID vaccine uptake should be compared with the COVID diseases. And I think the choice is very clear if you do that.
Thank you so much. Thank you. Okay, so we've heard from our experts now, some of our experts, and why they took the vaccine. There are some questions in the chat, and what I'm going to do is just read out some of the comments. Some of them have been sent to me personally. And one of these, it is interesting that they've said that somebody said, I don't believe the data that is out there because it's being manipulated for political interest, that they feel almost bullied to take the vaccine, and this has become unrelenting. Now, what I will say, this section of the meeting, if you look at the program, is the doctors. We have no politics. They were here because of our medical interest. The politicians are coming later, and you can direct those comments to them. But we really are here because we know that as doctors from an ethnic minority background, that we know our community usually puts their trust in us, and we're just here to tell you about our experiences and answer your questions. So if you've got questions, if you can just put them in the chat box, and I'll direct them to my colleagues to answer them.
Can I just make a brief comment on that? The political, you know, like everything in life has politics in it. I mean, we can't really move away from politics. I mean, the key point to emphasize there is that most clinical trials involving the vaccine were conducted, at least in the United Kingdom, by publicly funded agencies such as NIH, and there is no commercial interest in that kind of process. So we need to trust that process, because NIH, I mean, I've been involved, many of my colleagues have been involved in it directly or indirectly. It maintains very high standards. I understand where this suspicion and doubt about political imperatives is coming from. I mean, I share some of those views, but however, publicly funded research, Britain leads on it. Headed by the National Institute of Health Research, that is not commercially influenced at all. And therefore, those trials are reliable, and therefore the data that is out there in relation to vaccine is as reliable as any clinical trial that you would find out there. I mean, I think that point needs to be made. Thank you.
Thank you. Okay, we have about 25 minutes left, so I'm going to ask my colleagues to try and keep their answers to the questions really brief, so we can get through as many questions as possible, if that's okay. Okay, so Benita, would you like, there's a question about prevention and transmission of COVID-19.
Yeah, so
hi Benita. Yeah,
hi. Yeah, so I think what my fellow panelists have put really well is that the vaccination is really only one part of the solution. It is one part of the exit strategy to lockdown and what we find ourselves in. And there are some really key things about transmission. So we know that COVID-19 is spread by droplets that come from the respiratory tract, and they're breathed out into the air, and that they can travel around the distance of 1 meter. So the social distancing rule is because if you stay at least 1 meter away from somebody, then you're less likely to contract it through the droplets. The mask wearing is also an important measure. And we do know that as well as droplet spread, you can contract COVID from surfaces, which if somebody sheds virus into surfaces around them, somebody touches it, then you touch your eyes, you touch your face, it can transmit that way. So the measures that have been put in place around public health, social distancing, wearing masks, hand sanitizing, hand washing are vitally, vitally important to stop the transmission and spread of this disease. And the vaccine also, the early evidence suggests that it will reduce transmission as well. So it's all of these things that we must adhere to and keep doing if we're going to get out of this situation that we're in.
Thank you, Benita. That's really, really good and clear. Can I ask Vanessa? Vanessa, you here?
I am.
So, yeah, just to say a little bit about the COVID vaccine in pregnancy.
No, definitely. So, and very common questions that I get asked is about are the vaccines safe in pregnancy? And so what I have been emphasizing, and there's some really good guidelines, and I'll put them in the chat, is that as far as we know, there is no reason to think that the vaccines will affect pregnancies and the outcomes. Now, it's important to recognize that in any clinical trial, when we're thinking about pregnant women, in terms of ethics and including women in the trials, there is always caution about including pregnant women within the trials. So they were not in the early trials. So the data was not in pregnant women. But as we understand how vaccine vaccines work. There is no reason to suggest that there will be any complications in women that are pregnant that have the vaccine. And also to say that there are now going to be studies that are upcoming that will include pregnant women within the studies. And I have to emphasize, as my colleague said, when we're thinking about vaccines, thinking about the risks and benefits. And what we do know very clearly is that the risk of COVID within pregnancy itself. So the risk of acquiring COVID if you are pregnant. And there is, what we have seen is a risk of poorer outcomes, a risk of prematurity. So we do know that we want to, when balancing it, if someone is pregnant and they are in a risk of high risk of exposure, then we do encourage them to take the vaccine.
Thank you very much. Diane is here now. Is Diane here? Diane? Okay. What I'm going to ask one of my colleagues to do is also, it's been in the news, it's really topical at the moment, and that is the concern about thrombosis with the AstraZeneca vaccine, because this is what's been talked about over the last few days and why it's been withdrawn in a number of countries. Any of my colleagues have any experience or any knowledge, can talk about this?
Can I just say something very quickly? Sorry, Benita, carry on.
So Benita, would you like to say something, and then I'll hand over to Mahesh?
Yes, I must admit I'm very baffled by the whole situation that's happened with the AstraZeneca vaccine. And when we've looked at, well, when I say we, I know AstraZeneca have looked at the results from all the trials and also from the real world evidence that we've got. What they found is that the incidence of blood clots is no different to what you would normally expect in the usual population. So blood clotting, surprisingly, it might surprise you, is not a very rare condition. You will know people yourselves who've had a clot in the leg or a clot on the lung. There is a natural occurrence of this in the population in the background. And so some people who have the vaccine will inevitably go on to have a blood clot. And the important thing here is whether the vaccine caused the blood clot. There is no evidence in any of the trials that I'm aware of, that we are aware of, that there is an increased risk of blood clotting. So it's a very unusual decision that's been made by the countries to stop the rollout, given the lack of evidence for the concerns. But I know that WHO is now looking at this, so we'll get more information over the next few days. But at this moment in time, we do not believe there's a risk.
Thank you so much. Mahesh, we're going to make a comment.
Yeah, just to add further, I mean, just to put some numbers, the incidence of blood clots forming in the legs, or what we call deep vein thrombosis, is roughly about 1 to 2 per 1,000 people. And this is without anything to do with COVID or vaccine or anything like that. And the incidence of somebody forming a clot spontaneously in the brain is about 1 in 100,000, kind of that. So there is a natural occurrence to this. Now, in the context of vaccine, in the context of COVID infections, if people get dehydrated, if people are not mobile for any reason, whether it's a vaccine-related flu, not feeling very well or pain or for what, if people are immobile, people are not drinking enough, people are not moving enough for whatever reason, then the incidence of that clot formation can be slightly higher. So at the moment, there is absolutely nothing to suggest that the AstraZeneca vaccine is associated with the higher risk, though some countries have raised concerns about some of the initial reports that are coming through. But if people are this is what I told my wife when she went for the AstraZeneca. She asked me this question. I said, on a risk benefit, at present, where we are in terms of our current knowledge, the right thing is to take the vaccine. But if you are concerned, make sure that you drink plenty of fluid, make sure you don't lie in one place, make sure that you move your legs, make sure that you are physically active. And that's what she's doing, and she's gone shopping.
Thank you very much. That's very reassuring. Vanessa, thanks very much for all the links you've put in the chat to the Royal College of Obstetrician guidelines.
Great.
We're going to attempt to invite Dr. Diana Santa, GP again. Are you here, Diane?
Yes.
Thank you.
I am here. I'm really sorry. I've literally just walked in from work, so I'm sorry to be late. Right.
That's
So
okay.
good evening to everybody and to all of you online today. I just want to add something very small in addition to what my colleagues have said relating to why they went forward for the vaccine. I obviously working in general practice, we get to see the sort of mild to moderate COVID patients, or patients who don't necessarily have to end up in hospital or in ITU or need extra support in hospital. And we've all been hoping and praying for a solution. So obviously when the vaccine came through, we were very pleased. I did have concerns at the beginning with how quickly things had been done, but there's a lot of reasoning behind that because all the effort had been put into it. It was a global concerted effort to get this vaccine sorted so that we can, the whole world going through this, can get ourselves out of this. Obviously with the large numbers of people that had been infected by COVID and that were experiencing the same problem, there were lots of people who were willing to volunteer into vaccine trials to get the vaccine trials done. So all the concerns that people might have are legitimate, but there are reasons why the vaccine is safe and is efficacious, and it has gone through all the rigorous testing. From a personal point of view, I see patients who have had COVID and the effect it has had. We're seeing a lot of patients with long COVID at the moment, patients who've had COVID who 4, 5, 6 months down the line are still feeling very short of breath, still feeling very lethargic. I had a lady who I spoke to yesterday and she's still very breathless. It just takes a very little thing for her to get out of breath. She used to be able to do everything without any restriction, and now she can barely sort of do 100 yards and she's huffing and puffing. The people who are concerned and mentioning ongoing chest pain, chest sort of tightness, chest discomfort with no other clear cause. We've investigated it, there's been no other cause, and they've had COVID in the past. We've had patients who just feel drained all the time. We've got patients who constantly have headaches. I've even had a lady who still hasn't had her smell return. So just to buttress the points that my colleagues have said, it's much better to not catch the COVID in the first place, or if you do catch the virus, for your body to be able to overwhelm it because you've got the immunity to it. And that's why the vaccines are one of the ammunitions that we've got in our armory to do that. I had my Pfizer vaccine in January. I had the second dose 2 days ago, and I've been fine. The first dose, I didn't feel anything. The second dose, I felt a little bit tired and a bit sort of sleepy that day, but that was it. The next morning, I was perfectly fine. So that's all I've got to sort of add to what my colleagues have said about having the vaccine.
Thank you very much.
Can I come in?
There's still sorry, there are a number of questions, and one of the questions that are coming through the chat about immunosuppression. So I'm going to ask Dr. Sunil to talk about that. And if you can just keep it brief, because we're almost out of time, and I want to make sure I get through as many questions as possible. So Dr. Sunil, if you can talk about immunosuppression. We've got patients who've had cancer, who are asking questions about what are their options for having the vaccine.
Absolutely. Thank you. That's a really important question. And even the doctors themselves ask that question quite often because those patients were not part of the initial studies. There are two things actually to say. Some of the patients who are immunosuppressant drugs, they don't want vaccine to stimulate that immune system because some of the reason they are immunosuppressive drug is autoimmune disease or organ transplant. One thing I would say is when the vaccine, the response is very specific against coronavirus. So taking vaccine is not going to suddenly make your autoimmune disease or organ transplant at risk. That's one thing. The second thing is at the moment, we don't know how well the immune system will respond to the vaccine. And there are studies ongoing both in America and UK. The MRC funded £1 million study only a couple of weeks ago called Uptake study, where we're going to recruit thousands of patients across the country to look at exactly how well it protects, what proportion of it protects, and whether we need to tailor the treatment, such as the dosing or more vaccine later on. But at the moment, I think everybody should go for the vaccine. It is a safe thing to do, even if you're immunocompromised, and more studies will be available to guide us further.
Thank you so much. There are questions about the what alternatives to the vaccine can you have if you've got really bad allergies? Anybody wants to take that? Are there any alternatives if you've got really bad allergies to the vaccine? Allergies in general.
I think there are current guidelines. Unless you have a history of very severe, having developed severe anaphylactic shock. Now that's a very life-threatening specific condition. Unless you have had that for a recognized component of that vaccine, all other groups of people, despite their history of allergy, can have the vaccine. I think that's a recommendation. Now, obviously, you have to tell it to the people concerned so that they can take the right kind of precautions, right kind of make sure that you are there for the right kind of time and all that kind of stuff. So unless you have a history of specific anaphylaxis kind of allergy. Now that's a very severe life-threatening form of allergy to components of the vaccine that you are taking. All other groups of people with histories of allergy can have the vaccine. That's the current.
And I suppose it's important to stress that if you have then the vaccine, if you've had an allergy or an anaphylaxis to a component of the vaccine, then the vaccine isn't for you. But you should discuss this with your GP, because as we've just discussed, not everybody can have it if you've had an anaphylaxis. I'm going to direct this question to Vanessa. I'm breastfeeding, and can I still have the vaccine? And if I can, which one should I have?
Okay, so thank you. To emphasize, at present, there is no known risk in giving COVID vaccines to breastfeeding women. Now, and breastfeeding women will be offered the vaccine if they are eligible, so when their priority group is reached. Now, I am also really clear when I speak to women that we do have a lack of safety data in this group. But again, similar to pregnancy, we have no reason to believe, based on science, based on our long-term knowledge of other vaccines, that there should be any concern. So there's no known risk at present in giving it to breastfeeding women. Now, in terms of which one, again, the choice of which one always comes up. And I always emphasize that if whichever vaccine that you're able to get, please get that one. There is no sense of one is superior in a specific situation. The only situation that we would say consider any difference is in, as my colleague just said, if you had an allergy or anaphylaxis, sorry, should I say, to a specific element of one of the vaccines, and then you may be advised to take a different vaccine if appropriate. But that is the only instance. In terms of safety, in terms of efficacy and effectiveness, as we've learned, they are the same. So whichever one is appropriate.
Okay, thank you so much. There's a question here. With the numerous mutations of COVID, as with other medicines, surely we'll reach a point where the vaccines will not be as effective. Is this a concern going forward? Anybody want to take that question? Shall I give it to our GPs? Because I just feel like the GPs are more likely to face these sorts of questions because you're on the front line. You're seeing our patients first. So, Diana, would you like to answer that question?
Yes, thank you. That's a very legitimate question to ask, because we are seeing lots of variants coming up. And so rightly so, people should be or could be concerned about that. So the good thing is that the vaccines that we've got have very high efficacy and effectiveness rates. The surveillance, the genomic surveillance are monitoring things very closely. So as mutations happen, as variations happen, if there is the need to develop changes going forward with the vaccines, these will happen. So I'll give you an example. It probably isn't directly comparable, but the flu jab is one that goes through changes every year, depending on what the dominant strains are for that year. So if we have a particular strain that's dominant, then the flu jab is designed to make sure that it is able to capture those dominant strains. So I'm sure that as we go forward and these new variants evolve or these mutations happen, there will be ongoing surveillance, as is the case. And if changes have to be made, then they will be made as we go along to make sure that they're effective. For people who have had vaccines already, it doesn't mean that you will no longer have a protection against, because your body will generate some level of immunity anyway. which should be sufficient to keep us going forward. But if we need to have booster doses and that's the way things have to be, then fair enough, that's how it will be. We're used to having jabs that require booster doses anyway. Thank you.
Thank you so much.
And also, this question of mutation can be discussed in terms of all the infections that are there. So one needs to be optimistic. Of course, mutations are possible, but one needs to be optimistic that humanity and biology will find a way around it. So please be optimistic. It's not doom and gloom out there.
Absolutely, Mahesh. Thank you. Benita has, for those of you who are looking at this online, Benita has been providing some responses to the questions about blood clots. Benita, would you like to just articulate those for those of them that cannot see the chat?
Yes, I just wanted to make the point as well that severe COVID infection itself is very highly blood clot generating. So one of the big problems that we've seen on intensive care on the wards are extensive blood clotting in people with severe COVID disease. And there is no evidence at all, as we said earlier, that the vaccine itself causes a higher rate of blood clotting than in the general population. So it's all about risk and balance. And actually, by having the vaccination, arguably, we're reducing the incidence of blood clots if we're reducing the number of COVID infections. So I think it's about balancing all of these things. And it can be quite difficult when you're reading the headlines that you're reading at the moment.
It can be. I think the headlines are concerning for all. There's a question here about the COVID vaccines were developed really quickly. And is that not the reason why we're seeing some of these side effects that weren't highlighted in it originally? Can someone just talk about why the vaccine was developed really quickly? Anybody like to take that?
Yeah, I could perhaps. So what you need to know that although the vaccine came very quickly, the reason that came quickly is all the resources across the world in the research were put into this type of studies. I know as a researcher myself, all the clinical studies and research that I were involved were stopped. All my research nurses, the fundings were directed. That's first thing. The second thing is the basic structure or basic technology was developed over the last 10 years. It was just adapting to coronavirus situation. So although it sounds like it all happened within months, it is actually a hard work over a decade, plus all the resources that we had as a humans to put into in the last few months. I do understand, the concern about some of the side effects, and I think some of them are genuine, and those uncertainties we will learn with time. But all the side effects that we are having a causal relationship could be just naturally occurring. Just because people had vaccine doesn't mean that they can't get a heart attack or can't get a DVT or can't be unwell. We all get unwell every day, whether we have vaccine or not. So really be careful not to link with something that could have happened anyway.
Thank you for that question. There's another question about, do you feel that the AstraZeneca vaccine has more side effects than the Pfizer vaccine? As scientists, I know how we feel about some of these questions, but these are questions that, the members of our community are really concerned about. So if someone wants to respond, Mahesh, would you like to respond to that?
It's really important to emphasize that at present, there is nothing to say that one vaccine is superior to the other. This argument about 65% versus 85% versus 95%, these are distractions. The way I chose to look at the vaccine is that is there a sufficient history behind this? And as Dr. Sunil Daga has explained, yes, the technology is about 10, 15 years old. So we have sufficient history. All vaccines are sufficiently immunogenic. They're all producing the right kind of antibodies and cellular reactions. And now with millions of doses administered, we know that all these medications, all these vaccines have got sufficient safety profile to be recommended across the board. And then now you can go around looking at little questions and asking, is this right? And that kind of question can be asked in relation to any drug that you take. So we have to act by what is in front of us now and weigh that against the risk of getting a severe COVID infection. And on that basis, whatever vaccine that is offered to you, we need to take it for the sake of your health and for that of the others around you.
Thank you. I think the concern is, though, that if you have whole countries withdrawing a vaccine, it does leave people who are in other countries that are still giving it some concern. And that's what we just have to accept, that it will make the uptake of AstraZeneca, because there are questions in the chat that, can I choose which one I have? And these are questions that people will have.
That's a fair point. That's a fair anxiety.
Yeah.
That's a fair anxiety for that people are having. Yes, of course.
And I think one of the things that we have to be cognizant of is that, as I said at the beginning, having legitimate concerns about something and wanting to get the most up-to-date information and arm yourself with that before you make a decision is completely right. And I've seen some of these misinformation videos, and they can be quite persuasive. And it is not just the BME community that are hesitant. I think if you show enough people videos that are really compelling, everybody will stop and think twice. But that's the reason why we're here, as GPs and doctors from their communities, just telling people, explaining why we've had it and why we trust the vaccine program. So I'm going to end with one question from Dr. Yakubu. Are you still here? One of the questions that have come up is that about the question about ethnic minorities, because some people are questioning the data about that. So Yakubu, from your experience, in your clinical experience, did you see more ethnic minorities presenting that you had to do interventions like tracheostomies?
Yes, that is definitely the case. My first encounter with large number of ethnic minority affected with this is in the intensive care unit when I got involved with the tracheostomy. And I looked across the entire intensive care unit, and I would see that over probably 60% that were intubated there were people of color, either Black and Asian ethnic minority. And that really struck me hard. But not only that, in my clinic, my airway clinic, almost 90% or so of patients that comes in through the door with breathing difficulty and severe loss of voice or swallowing problem are the ethnic minority. And this is why I think really it's not just something that we hear in the news. I've come face to face with by encountering people of color suffering from a severe form of the COVID and the complications that follows that as well.
Can I just come in there quickly? I think, can I just come in?
Sorry?
Can I just come in there quickly about the infection rate as well?
30 seconds.
Yeah, I think it's just not just the people who are admitted to the ITUs who are represented in ethnic minorities. It's also people, the general infection rate, whether in general population or in healthcare workers as well. There's an increased risk of having the infection itself. Obviously, if you have infection, you go to the hospital, and there is 10% go to the ITU. So there is and then even among the healthcare workers, we have seen that people who are ethnic minorities living in more deprived areas, there is increased risk of infection and increased rate of developing the long-term symptoms because of that.
Thank you, Prash, as the last word. And I think some of the questions have brought up more questions, but our colleagues in the second half are going to help to answer some of that, because there's an intersection of race and inequalities, and that perhaps some of our colleagues in the second session could make that clearer. So I'm now going to hand over to Yvonne Coghill and David Weaver, who will discuss what they're going to do and introduce themselves. And I hope you've enjoyed the first session. Thank you very much.
I want to help you spot false information online and stop its spread. There are 3 simple tips. Look closely. Does the information seem trustworthy? Check. Is it coming from an expert? Still unsure if it's true? Don't share it. Check before you share.
You're on mute, Yvonne.
Yvonne, you're on mute. You're still on mute, Yvonne. Yeah.
I think it's the phrase of the century, apparently.
Can you hear me?
We can hear you now, Yvonne. Thank you.
Thank you so much. And thank you so much, Ngozi. That was fantastic. And listening to those doctors was was for me really inspiring. My name is Yvonne Coghill, and I am working for the Race and Health Observatory, which is a new body looking at how we can make things better for our Black, Asian and minority ethnic people across the whole of the NHS. And I have to say to you that listening to those doctors filled me with a lot of confidence, but also a deep sense of pride and joy, because you often hear that people from our backgrounds, you know, aren't competent enough, aren't good enough, aren't people who are, you know, you need to listen to. But actually, just listening to everybody really did fill me with a lot of joy and a lot of confidence. And the thing that I took away from that particularly was something that Dr. Patel said about comparing the vaccine with the alternative. I mean, nobody wants the alternative, which is to be really sick and to ultimately die. So the next part of the program is going to be listening to our policymakers, and we have some fantastic speakers for you this evening. And I'm really pleased and proud to be able to introduce the first speaker, which is the Minister, Nadeem Zahawi, who's going to talk to us. He is the Minister for COVID deployment, and we will all agree that it has been a real success story for the country compared to some of the other issues which we're not going to go into tonight. So I'm hoping that the Minister is with us and can actually kick off this part of the section. So over to the Minister if he's here.
Thank you very much, Yvonne, and thank you everyone, and I guess many thanks for the opportunity to hear from you this evening. But before I get into the details of what we are doing, obviously to tackle the critical issue of vaccination uptake rates in Black, Asian, minority ethnic communities, I think it's well worth reminding ourselves where we were at the turn of the year before the vaccine rollout really gathered pace. In the, I think, early January, feels like such a long time ago, we were seeing over 50,000, 50,000 new cases of COVID and around 4,500 people being admitted to hospital every day. And sadly, we were seeing over 1,000 deaths every day. Each one of those deaths was a grandmother, a grandfather, a mother, or a father, a daughter, or a son, or in my case, an uncle. Each of these desperately missed by their families and their friends. We know this was having and continues to have a real and disproportionate impact on Black, Asian, minority ethnic communities. And that's why it is critical that as many people from those communities get the vaccine as soon as possible. We know from recent research that a single dose of either the Oxford or the Pfizer vaccine delivers protection against severe infection in the over 70s with a more than 80% reduction in hospitalization in the over 70s. By the 15th of March, nearly 24.5 million people have received their first vaccination dose, with over 1.6 million who have received the second dose. Unfortunately, we are not seeing the same level of uptake in BAME communities. I spend a great deal of time talking to community leaders about how we can reassure people about the safety and the efficacy of the vaccine. And I hear about the issues they face, challenging rumors and misinformation peddled throughout some communities, fueling and allowing fears to really fester. These obviously create information gaps, exasperated by a sort of reliance on others to explain the science and falsely plugged by anti-vax agendas. For some, the speed of the vaccine production is unsettling. I get a lot of questions about this. Apprehension is natural. We must be able to describe the vaccine development stages and the safety of the vaccine, not only to those who are scientifically literate, but to all members of the community. I think with transparency, we can build trust. With clarity, we can build confidence. On the 13th of February last month, we published our COVID vaccine uptake plan with the aim to improve uptake across all communities. The plan takes a local community-led approach with support provided from us in government, the NHS obviously in England, and local authorities to coordinate and really enable action to happen. It includes engagement at local level, using really trusted voices, sharing examples of what is known to work and what was known to work well in nearby areas, and encouraging community-led efforts to address vaccine disinformation. It's those community voices that are trusted. And of course, through the Community Champions Scheme, councils and voluntary organisations are able to deliver a wide range of measures to protect those most at risk, building trust, communicating accurate health information, and ultimately helping to save lives. This will include developing new networks of trusted local champions where they don't already exist, because not every area has those networks. Just to close, Yvonne, I want to just stress that we must confront historic medical inequalities and provide accurate information on the development and safety of vaccines to build that vaccine confidence. These barriers will not be overcome overnight. However, we cannot allow the status quo to remain. We cannot stand by and leave people unprotected and put them at risk of the virus. The vaccine is working and is having a real impact, protecting the NHS, protecting individuals, and putting us on the right track out of this pandemic. And of course, I've actually just tonight had my text message, because we've just opened the system up to the over 50s, and I will be going to get my vaccine. I've been on the Novavax trial, but I've just unblinded myself tonight so I can go and have my vaccine. I want all sections of our society to be in that same position where we can benefit from the tremendous progress we have made over the last year. Thank you very much for listening to me. Very happy to be with you tonight.
Oh, thank you so much for that. And I have to say, the vaccine rollout has been, it's been a triumph actually. And lots of people have said it already tonight about how confident they feel once they've actually taken the vaccine. I myself have had I had my first dose, and I'm getting my second jab next week, and I'm really looking forward to that. But that's not going to stop me, I don't think, from wearing my mask. I think the mask has become a habit for me now that I don't think I'll be letting go of anytime soon, and I think that that's probably the case for lots of people. So our second speaker now is somebody who I've met recently and actually has become a really good friend of mine. She is a GP, and she is now the Director of Health Inequalities in NHSI, NHS Improvement and NHS England. So I'm really pleased and proud to present my friend Bola, who is, as I say, somebody who I think is going to make a huge difference. Bola Oluwabi. Bola.
Thank you, Yvonne, and thank you so much for the invitation to be with you tonight. I really do consider it a great privilege, and thank you, Yvonne, for the very kind introduction. I'm joining you today, as Yvonne has described, both in my role as a GP and a frontline clinician, and also Director with portfolio responsibility for health inequalities at NHS England and Improvement. And my reflections tonight are that the COVID pandemic didn't create health inequalities. We know that health inequalities existed way before the COVID pandemic. And we've had reports going back to the 1980s, whether that is the Aitchison report or the Black report or the Marmot report that came after that. And indeed, a lot of the insight that we've seen from Public Health in England's publications back in last year around the COVID pandemic disparities report, as well as the Beyond the Data report by Professor Kevin Fenton, who I know is joining us also tonight. And so I think the issue of health inequalities have been very well described and rehearsed over many years. And as a GP practicing in one of the most socio-economically deprived areas of the country in the northeast of Derbyshire, health inequalities is something that is very real to my practice. And so it's for me not a theoretical thing. I've always seemed to work in these areas of Derbyshire for many years. And so really to have the opportunity to contribute to addressing the concerns within the Black, Asian, and ethnic minority communities in relation to the COVID vaccine was a great privilege, because I'm sure you'll all agree with me that there aren't many interventions right now that we can do to tackle health inequalities beyond ensuring equitable access to the COVID vaccine. And I really do want to thank Minister Zahawi for the amazing work that he has led in ensuring that the UK is very much leading the way in terms of the deployment of this vaccine. Just want to thank him and acknowledge just what a tremendous effort it is and the significant improvement that it is yielding. My last several weeks have been characterized by webinars like this, talking to different groups of people, whether that is the Black, Asian, and ethnic minority staff networks, talking to faith groups, talking to groups such as this, really to try and increase people's confidence. Because at the end of the day, the one word that strikes me is the word trust. I think trust has been the central theme that has emerged for me in all of this. And just the realization that by going and talking to the community leaders and the faith leaders up and down the country, and really acknowledging people's concerns as legitimate and worthy of respectful answer is one of the things that I have found really powerful. And whether it's the piece that I did in the Voice online newspaper, which is the largest Black newspaper online, really addressing some of the issues that the other colleagues on this call have talked about tonight, the concerns around pregnancy, around fertility, around breastfeeding. And I find that in all of those engagements that I've been privileged to be part of, the thing that has been most impactful is for people to understand that their questions are legitimate, that they do have a right to pose their questions, and that those questions will be taken in the spirit of trust and respect, that people are seeking answers. My experience is that most people are not necessarily hesitant. What they're seeking is reassurance. And, as Minister Zahawi said, that, the issue of inequality is beyond the vaccination program. And so people are coming from a very deep place, from a very deep place of long-standing mistrust. And so one of the biggest learning for me is the power of the voice of community leaders, and I'm really encouraged when you begin to see how the uptake rates are going up. We still have room to improve. We still have way to go. But I reflect back to the uptake rates in the Black, African, and Caribbean communities in the middle of January, and indeed in the Bangladeshi and Pakistani communities when the data first came out. If you compare that to where we are now, we have made tremendous progress. And I really want to thank, organizations like CORE, like CAN, and several others like you, who have tirelessly, and I was privileged to be invited to a meeting with the Prime Minister last week, just to talk about the work that I've been doing in engaging all of these communities. And one of the things that I said to him was, organizations like CAN, like CORE, and others like you have been running webinars like this pretty much every weekend since April last year, only 2 weeks break in the run up to Christmas. And for me, that is the power of community mobilization. That is the thing that is starting to move the dial in the right direction. And I really want to take the opportunity of this evening to really thank you, because last year we were in a place of powerlessness where we didn't have the vaccine, but now we are powerful because we do have the vaccines, which do give us a chart to actually wrestle control back from this virus. And that's the thing that I want to say very clearly to our community tonight. You know, we have been disproportionately impacted by this virus on so many levels, whether in terms of the number of people who have died or people who have been left with life-changing consequences from having the infection, whether that is organ failure of various descriptions or the very debilitating long COVID that we've already heard about. I think, you know, it would be a travesty to come from that to then get into the summer of this year and for the overall death rates to have come down, but to discover that actually the death that we do have is still disproportionately in the Black, Asian, and ethnic minority communities because the vaccine uptake hasn't been as high as it should be. I really think that would be, for me, personally and professionally, it would be the most devastating thing to happen. And so I really want to encourage, you know, members of the community and colleagues like yourselves on this call to not relent in our determination to continue to answer those questions, to continue to build the relationships, build the partnerships, gain people's trust, because we have to win people's trust. You know, and I think it's important that we take that as one of our primary responsibilities over the months to come, to make sure that the uptake rate in our community is as high as it can be, so that we get further down this year and we don't see disproportionate death rates, you know, within our community, simply because the virus takes the path of least resistance, because that is the thing that will happen, is that if you find that the rest of the population has taken the vaccine, it will do what it does naturally, which is to find the path of least resistance and wreak havoc in the communities that are not protected and not vaccinated. So I just want to encourage CORE and CAN and several others that are working so hard in this space to keep going. And you know, and I'm committing as, you know, in my role, both as a frontline GP, talking to my patients, encouraging my patients, and also in my national role, I am committing to continuing to turn up at these webinars, you know, and to play a very small part, but an important part in addressing people's questions and building these relationships and partnerships that will help us to chart a course out of this dark tunnel. So thank you again. Well done for the work that you're doing. It is making a difference. It's working. Keep going. It's working. And just to say, we're all in this together. Thank you so much.
Thank you, Biola. That was brilliant. David.
I was on mute. Thank you very much, Yvonne. And I suppose in the spirit of what Boda has said, in terms of the tireless work that people in our communities and our clinicians and our specialists and experts have been doing, I'd like to introduce Professor Kevin Fenton and then Dr. Nikki Kanani. Professor Kevin Fenton, who is the Regional Director of Public Health, NHS London, has been someone over, right from when this whole piece started, has been out there and yeah, having the difficult, challenging conversations with ministers, with civil servants, and also engaging with communities, right up until very recently. I know you did, Kevin, some sterling work in Westminster and other areas with my friend and colleague, Lord Simon Woolley. So I'd like to welcome you, Professor Fenton, and thank you very much for coming.
David, thank you so much, and good evening, everyone. It really is a pleasure to be here with you this evening to join this conversation and to listen to the fantastic questions that you all have been asking this evening. And one of the things that I have learned as we've embarked upon this journey of really understanding and rolling out the vaccine is that it is critical for us to meet communities where they are. It's essential for us to listen to your questions and your concerns, because it's in the conversations that we build confidence, and it's in the conversations that we get to a different and better place. So as you've heard, I'm the Public Health Director for London, and I've had the privilege of serving in the city over the past year since the emergence of the pandemic. And for those of you in London, you know the toll that the pandemic has had in our city, with more than 700,000 Londoners being diagnosed with COVID, and unfortunately more than 18,000 Londoners having died from this disease. And as I've heard from so many of you this evening, this pandemic has touched all of us, whether through our physical health, mental health, emotional health, and well-being, or those who we love. And so we are poised now to see the end of this pandemic. And we know over the past year that we have been learning about the tools that we need to protect each other in order to reduce transmission. So whether it's a hands-face space, whether it is ventilating the places that we're in, whether it is testing and contact tracing, all of those things over the past year, we've learned about managing this pandemic and living with COVID. But now we are poised to see the next phase of our response to this pandemic. And it is a phase which I'm most excited about, because a year after the discovery of this virus and a year after naming this infection, we now have the tools to most effectively protect ourselves from infection, and most importantly, to protect ourselves from severe disease and death. And this is really important because in the last year, we have seen that our community has borne the brunt of severe disease and death. When we started looking at the first wave of the pandemic, we described the disproportionate burden of COVID severe disease and death on Black, Asian, and minority ethnic communities. And in London, in the first wave, Black African and Black Caribbean communities had some of the highest rates of infection, as well as higher rates of death from the disease. In the most recent second wave that we've seen in the city, we've seen this disproportionate impact on our communities as well. But this time, most recently, in January, February, we saw South Asian communities in London being more severely affected, followed by Black African and then other communities in the city. So I am concerned about the disproportionate burden that this epidemic is having and has had on all of our communities, but especially our Black, Asian, and minority ethnic communities. And this is not just a concern for older people who are at higher risk of severe disease and death. As you've heard from other speakers this evening, we are now seeing increasing numbers of people being diagnosed with long COVID. So people who may have had a mild course of infection, younger people, more women than men, becoming diagnosed with long COVID. And I'm particularly concerned that because our communities have had that disproportionate impact, that long COVID may also be disproportionately affecting us in the months and years ahead. So, looking at lessons then from London and what we now know, and what does it mean for how we roll out the vaccine and how we engage communities? Well, like so many of our colleagues on the line this evening, I have been really engaging with partners, listening to communities about their concerns, their hopes, as well as some of the opportunities for vaccines. And we've heard constantly questions being asked about safety, the content of the vaccine, how fast it was developed, whether or not it's safe, pregnancy, reproductive health, and the vaccine. So I'm really pleased that those questions were asked tonight, because it's important that we continue to speak about them. As we move through the implementation in London, we are seeing differences across groups. Londoners who are living in more deprived parts of the city have lower rates of vaccine uptake. We see differences across racial and ethnic groups, with South Asian heritage Londoners being less likely to take up the vaccine than white Londoners, and Black Caribbean and Black African Londoners having some of the lowest uptakes across the city. But as you've heard from other speakers, we are seeing improvements week on week. And it is important that as we now progress with unlocking the city and progressing along the roadmap, we're opening up the city once again, that we are as protected as we all can be. And that's where vaccines are key. So in closing, I'm often asked, why get the vaccine? Why is it so important that we're all protected as we are navigating this pandemic? I'm going to close by just reinforcing 3 key lessons that I've learned over the past 4 months as we've embarked on the rolling out of the vaccine. The first is that the vaccines remain the most powerful tool that you and I have to protect ourselves and our loved ones against this disease, and to really protect us against severe disease and death. It is the most effective tools, and it's now within our grasp. Second, it's much better to have the vaccine than to have the disease itself, because of the impact that we know that this disease has had on death, as well as the disability from the disease. And we know that the risks that many of us have been speaking about and that you've been asking about today are far less than the risk of getting the infection, and its complications are much greater than any risks from the vaccine. And then finally, as we prepare to unlock and to re-enter society, to continue mixing, to re-emerge into our jobs, into our social events, it's important that we do so as protected as we can be. And the vaccines are key to that. So Yvonne, over to you, and I look forward to the discussions this evening. Thank you.
Okay, it's over to me. But that's fine. We're working in partnership here. Professor Fenton, thanks very much. That's really clear in terms of the importance of the vaccine. If I can introduce Dr. Nikki Kanani, who is a GP in South East London. And Nikki, if you just explain a little bit more about what you do, but we know that you've been doing some sterling work in this area as well. So Nikki.
Thank you, and thank you for having me. Yes, I'm a GP in South East London and medical director for primary care at NHS England and in NHS Improvement, and spent probably most waking hour since the week before Diwali on the vaccine programme, and I'm very proud to have done so. So first of all, thank you for having me. What fabulous speakers and content, and it's lovely to see so many familiar names both presenting but also in the audience as well. I feel very much surrounded by friends, so thank you for having me. Look, I can't add much after my fantastic colleagues, but I wanted to just draw out a couple of key points. One about some of the work we've been doing with communities across the country and how that's going to become part of the legacy work that Bola describes. I think it's worth talking a little bit about AstraZeneca and the reports around blood clots, because I know that's worrying people. And then some top tips that I think that we're learning and seeing from local systems. So as the Minister said, we've already seen the role that communities that you're part of have in encouraging vaccine uptake. It has been genuinely incredible, showing what happens when a local community works in partnership with its health system, with faith leaders, community leaders. And what we've seen is that we are making sure that no one gets left behind. And that has been a core tenet of the vaccine programme since we started, that everybody who wants to have the vaccine can have the vaccine, and that we can build vaccine confidence. And that's what it is. It's about building vaccine confidence in a way that will promote not just this vaccine uptake, but actually promote trust and confidence more widely. And we know that trust and confidence and historical experiences really create a set of barriers to accessing the vaccine. So try to strip those away in different ways, and I'll talk about those in a moment. So we know that vaccine hesitancy is much lower in England than in many comparable countries, but we know that the willingness to take the vaccine is not the same across all communities. And what we're doing is working both nationally and locally to make a difference across communities and groups. So working with partners across government, as the Minister mentioned, but also with partners in the faith and voluntary sectors to locally help to build vaccine confidence. And particularly in this case, across our incredible ethnic diversity that we see at a local community. And what we've seen is the best success in improving uptake happens at a local level, when we essentially are handing over vaccine delivery to the local community. So often it will be the local community that is advertising and booking in people in that community, and because they have the existing relationships and a really deep understanding of local communities. And faith and community groups are also crucial for getting vaccine messages out. You make up the trusted voice that we have, and so we are trying to work with groups who want to host virtual events such as these, either by speaking at them or helping to facilitate them, and sharing guidance on what works best for events and providing speakers as well. So trying to do things in different ways. One of the great things that we've been able to do is support places of worship that want to become vaccination sites. So although we have over sort of 1,600 vaccination services in the country in all sorts of different places and locations, more than 200 of those are pop-ups. So pop-ups in gurudwaras and temples and in mosques. And that's exactly right, because we want to make sure that the vaccine comes to you, to your community, to our community, and so that it feels accessible. And the really good news is that across the first 5 priority groups, most people across all ethnic minority groups have already taken up their first dose. And the total number of people receiving their first dose more than doubled across the month of February. And the rate for those who are in an ethnic minority group rose at an even faster rate. And what we've seen is that the fastest rate of growth was for people from a Pakistani background, which nearly tripled, and a number from the Bangladeshi background, which rose at a rate of 3.5 times. So 3.5 times more people vaccinated at the end of the month than the start. And what we're trying to do is track interventions against that to see what's made the difference. And we've seen that there are a range of things, as I've mentioned, removing barriers to access, building strong community messengers and messages, sharing resources so that we can tackle misinformation and disinformation, and fundamentally developing resources that allow local communities to offer the vaccination within their own space and within their own faiths, making sure that we support local communities. And we've seen incredible work in Liverpool, in Leeds, in Solent, in Nottingham, and we really want to see more. If you're in a community and you're keen to do something differently, I will put an email address in the chat bar so that we can give you the support you need to make sure that we get the maximal uptake of vaccine. So I know, so if we can just touch on Oxford AstraZeneca for a moment, we know that lots of people will have seen the reports from the EU and be worried. The MHRA, which is the expert body on vaccine safety and effectiveness, and have approved our vaccines, have been absolutely clear that people should still go and get their COVID vaccine when asked to do so. The European Medicines Agency has said the same as well. Blood clots do occur naturally, they're not uncommon. And over 11 million doses of Oxford AstraZeneca vaccine have now been administered across the UK, and 17 million across the UK and EU. And the number of blood clots reported after having the vaccine is less than the number that would have naturally occurred in a population anyway. So as the MHRA safety lead says, Phil Bryan, while we continue to keep looking at safety and data reports, the evidence does not suggest that the vaccine is the cause. You are more at risk of blood clots from COVID infection itself. So please, if you are offered the vaccine, if your communities are offered the vaccine, or if your communities are worried, please support them to feel confident about taking up the vaccine, because the vaccine is what's going to save your life and save the lives of your family and loved ones. So my key messages: continue to follow all the guidance to control the vaccine, to control the virus and to save lives. So that means still staying at home and following hand, space and face guidance when you're out. Don't contact the NHS to seek a vaccine. We'll get in touch with you. And when we do get in touch with you, please attend your appointments. And what we want to do is really bed this into legacy to make sure that we can make a change for the future, not just for the present. And I'm going to finish with Amanda Gorman's amazing inaugural poem words. And she says, "We are striving to forge our union with purpose, to compose a country committed to all cultures, colours, characters and conditions of man. And so we lift our gaze not to what stands between us, but what stands before us." And I'm confident, working with yourselves, we can create a legacy shift in the way that we support our communities to take up health interventions. Thank you.
Thank you very, very much. Really powerful, really inspiring, and a real call for action to really do the right thing based on the facts. So thanks very much, Dr. Nikki Kanani. I'm going to pass over to Yvonne now. We're going to enter plenary stage where we can ask questions of the panel and do get engaged with that. So Yvonne.
Thank you. And thank you for that, Nikki. It was absolutely brilliant, as always. It's absolutely my pleasure to be able to open up this plenary session with these wonderful speakers. And it's your opportunity now to ask the policymakers, the people that are leading the vaccine rollout, the people that are actually making things happen on the ground, any question that you would like. And so, you know, we're asking you to ask these questions in the chat box. I don't know, is the minister still here, or has he gone?
No, I'm here, Yvonne.
That's fantastic. No, that's brilliant. I'm waiting for all the questions to come in, and if not, I have a question, and it's something that Kevin mentioned when we had a webinar before, and it's about trust. Kevin, and I've never forgotten it, and I use it all the time. I've stolen it from you, Kevin. He talks about consistency and truth over time, making people more trusting of the system. And what we know is that over a period of time, the consistency hasn't always been brilliant, and we haven't had the length of time to get people to actually start to believe in what we're doing. What would you say to people who say that they don't really trust the system with regards to the vaccine and the vaccine rollout?
Thank you, Yvonne. I guess I completely understand where that sentiment comes from, that emotion comes from. And I think actually in many ways, and I've been discussing this with both Nikki Kanani and obviously with Simon Stevens, who's the Chief Executive of NHS England, and with Emily Lawson, who's the Senior Responsible Officer for the deployment of the vaccination program. I think it's an opportunity for us in a way that hasn't really been available before. This is, you know, the largest vaccination program in the history of the NHS, but also in our country's history. And many communities say to us now, some of the evidence from everything you've heard about tonight from the Uptake strategy, is they say, actually, you know, of course you want us to get vaccinated because it's the right thing to protect the country. We know why you want us to do it. Obviously, it's also good for us and everything we've heard tonight about protecting themselves, their family and their community. But also, we want to hear more from you as government about health inequalities. You know, will you be there for us in the longer term? And I think it's an opportunity, whether it's around, you know, issues around, you know, family or in social care and healthcare integration, all that, you know, stuff that I think, you know, we want to make sure we deliver on, is now an opportunity, because the vaccination program has forced upon us an interaction with communities at an individual level like none ever before.
No, thank you. Now, thank you for that. And now the questions are coming in fast and thick. I've got another one for you, Minister. It's from Maurice McLeod, and he asks, can you ask the Minister to confirm once again that domestic vaccine passports will not be used as a way to further marginalise communities which are already marginalised? So a tricky question.
Thank you very much for that question. And I completely understand where it comes from. And I think the Prime Minister, when he set out the roadmap, actually addressed this head on. So internationally, we know a number of countries now are requiring, or at least they're indicating, Cyprus, Greece, Portugal, other countries, that they will need some form of vaccine certification in the way that they need a certificate for pre-departure test, as we do. We need a certificate for pre-departure test. So internationally, we are moving forward as a sort of international community to try and shape those global protocols around travel. And the Secretary of State for Transport is leading on that. And if it's going to happen, then we might as well shape it in a way that is advantageous to our citizens. Domestically, which I think where the question is coming from, you're absolutely right. It has lots of real difficult questions to answer, which is why the Prime Minister has asked Michael Gove, the Chancellor of the Duchy of Lancaster, to conduct a review into how we certify whether it's for testing or for vaccination. But those difficult questions around discrimination and obviously personal information have to be addressed in that review. And Michael Gove will be reporting back by the 21st of June on that. Hence why the domestic issue around certification, both for test and for vaccination, is a much bigger thing, and it's not something to be done in any way lightly.
Thank you. David, have you got a question?
Yeah, a question's coming. A couple of questions are coming on this particular point, really, which is, how do you build confidence with South Asian communities if there's vaccine hesitancy among some South Asian medical and healthcare professionals? That goes also for African Caribbean communities. That's been coming up a lot. If there's a hesitancy there, how do you build that confidence?
I think, but from my perspective, I hope Nikki and others and Kevin's work has been phenomenal in this area, as has Nikki's work. It's about having these sort of interactions, and as we did right at the outset, actually bring the Joint Committee on Vaccination and Immunisation, bring the regulator, the MHRA, much closer to the practitioners on the front line who are from Black and Afro-Caribbean communities, who are from South Asian communities, and they were asking their questions. And I was part of those sessions where they were asking about the phase 1, phase 2, phase 3 trials of the vaccines, of the JCVI and of the MHRA. How do they conduct their regulatory approvals? What do they do? And they confirmed to them and reinforced that there were no shortcuts. It was essentially because so much resource was put in. Normally, the trials are done sequentially. You do phase 1, you wait, you raise more money or you invest more money. Then you do phase 2 and you wait and you raise more money, invest more money and do phase 3. Because money was not an issue, they were able to parallel the phase 1, 2 and 3 studies.
Thanks. I've got a quick question for Nikki and Kevin and Bola, and it's about no jab, no job. And people out in the system are really concerned that this is going to be the case, that if they don't have or take the vaccine, ultimately they will be out of a job. Have you got anything that you can say to respond to those concerns?
I'm happy to go, and if
tricky one, I'm sorry.
Can you hear me?
Yes.
Okay. Just say that I'm happy to make a start. I think I would probably flip that on its head by saying perhaps the conversation is not so much about will I have a job or won't I have a job if I don't take the vaccine. I think people's consideration should be more about what does it say of my professional commitment to protecting my patients if I don't take the vaccine. So this question has come up on a lot of forums that I've been on and several webinars that I've done over the last several weeks. And I think what people really need to consider is that whether you're a medic or a nurse or an allied health professional or a social worker or a carer, whatever capacity we happen to be working in, that is frontline, it really is a privilege, actually. It's an absolute privilege to be looking after people at such close quarters. And I think we've all taken some kind of professional oath of some description or the other to do no harm first do no harm. And I think right now, the most powerful thing we can do to do no harm, to not put people in harm's way from this virus, is to take the vaccine and everything else we need to do. So I don't think we should be having the conversation on the basis of whether my job will be taken away or not. It should be on the basis of what is my professional and human responsibility to protect others.
So I fully agree with that, Bola. I think that's a lovely way to describe it, and it's really important that that comes across in the messaging. I think the other thing is the programme, we see really clearly that our responsibility is to be responsive to the needs of a community. So somebody said to me the other day, you know, well, actually, if we're working shift work and it's overnight, you know, walking into a vaccination service Monday to Friday, 9 to 5 doesn't work. So what we need to do is create opportunities for the vaccine to go to people so that you can do your job, so you can take up the vaccine, not just with confidence and ease, but it's actually right there where you need to have it. So it might be that you're in the gig economy. It might be that actually your working patterns are different. And so what we're trying to do, and particularly as we go towards cohort 10, which is a younger cohort, and as many of you will be aware, with a different set of drivers and motivations, and added to that, restrictions will be lifting. It will become sunnier, better weather. People will feel less, will feel more complacent about taking up the vaccine, alongside all the other challenges that we've described. So we need to be really creative as a programme and support systems to look at a local community and say, well, actually, having fixed sites in 5 or 6 geographies isn't good enough in this area. We need to create pop-ups, we need to go roving, we need to come into the warehouse, you know, on a Friday night and make sure that we bring the vaccine to everyone who wants to take up the vaccine.
And Yvonne, just to say, I agree with both Nikki and Bola on this. One of the ways of looking at this is not necessarily what not having the vaccine will prevent you doing, but it's the opportunities that being vaccinated and having the confidence of that protection, what that will enable us to do. So whether it is going to work confidently, reducing the risk of infection either in the workplace or in the community. And as we proceed along the roadmap and begin to reopen our communities and society, to be able to engage with a bit more confidence than we have been able to in the past year. So reviewing it in terms of the power of the vaccination, both to protect our health, to protect those around us, and to allow us to re-engage with much more confidence than we've had in the past, I think is also going to be important as well.
No, thank you for those responses. I think really and truly those messages need to be pushed out there, because we're hearing the opposite, which is, you know, no jab, no job. It needs to be switched on its head. So thank you for that. David,
Sure.
have you got another question? Because I have.
I have actually a message for Minister Zahawi. Minister, I mean, some of the points are coming in and saying that actually this mistrust is just a reflection of the lack of trust that many Black, Asian, minority ethnic people have in general in relation to society and to government. And in terms of the messaging around this, shouldn't that be reflected by government resourcing Black, minority ethnic organizations to actually get that messaging out? And it seems to many that that's not happening. So you might put forward the whole piece around the facts. These are the facts, but it's not being felt. And this is a state of an emergency. And should not the government be actually resourcing Black, Asian, minority ethnic organizations, just like we're doing here, to actually get that message across?
Absolutely right. And just like we're doing here, I hope, you know, we're doing some good in getting that message out. What Dr. Bola just spoke about was so powerful, better than any politician can ever deliver. And it's that sort of message that we need to make sure is the one that we get out to communities.
I think we've lost.
I think
Professor Fenton, because I know that you've spoken in other settings about this very issue in terms of getting that messaging out and the best ways of doing that. And so in your professional opinion, how important do you think that is?
It's incredibly important. And I think one of the things we are learning as we embark on this journey on vaccination together with communities is that from some communities, this is the first time that the health and care system has been sitting down, listening to concerns, responding to concerns. And I hope that one of the legacies, one of the positive legacies of the pandemic will be the fact that we are now listening to and engaging with communities in a much more deeper way than we've ever done. And I hope that this is laying the foundation, not just for the COVID vaccine, but as we emerge from the second wave of the pandemic, to help us to deal with some of the other wicked issues that our communities face. So whether it is mental ill health, or some mental health issues that we're grappling with, whether it's other concerns about our physical health and well-being, or whether it's even jobs and education, we have got to begin that process of deeper engagement with our communities moving forward. And we're learning lessons now that I think will be critical for us moving forward.
Okay, thank you. Yvonne, anything else coming in your side?
Yeah, the questions are quite interesting, and I think that there's one here, and I think we've lost the minister, but other people can answer this. It's about the reason why, if we know that so many people are affected, people of colour have been affected by the COVID-19, why was it that we were not prioritised in the rollout? So that's one of the questions, and I don't know who can take that.
I think the minister's just returned. I think the minister's just returned just on time.
I don't know whether or not he heard that question.
No, you might want to repeat it again if you.
Okay, so basically the question is about the rollout, and if we know that people are from Asian and Black and ethnic minority backgrounds are disproportionately affected by the virus, why were they not prioritised with the vaccine rollout, was the question. We can't hear you.
Can you hear me now?
That's better. That's better.
I'm having a bad hair day. I've got no hair left. The technology is letting me down, but I'm determined to get back on. I wasn't going to just leave you with those. I don't know where I cut off, but I was saying we've got community champions, £23 million going into identifying community champions. We've got another pot from the NHS, which is about 4.3 million, that is allowing us to be able to do these pop-ups in churches. And I was at Jesus House the other day in Brent Mosque, where I was after Iftar in Ramadan next month as well, a vaccination pop-up. So after people have had their iftar in the mosque, they can have their vaccination as well done. But on the question that I think I've just heard, which is around the impact of the virus on our communities, and I speak as you know, someone originally from the Middle East, as is my wife, as you know, lots of people on this call here tonight, as well as Black and Afro-Caribbean communities. The Joint Committee on Vaccination and Immunisation, we set them the question to say, look, who should we prioritise? How should we prioritise when we start this massive deployment that I spoke about earlier? And they looked at everything from obviously ethnicity to profession, i.e. does your job put you closer to the virus because of your social interactions, teachers, police officers, and so on. And they came down very clearly on the age criteria, so the 1 to 9 criteria, but within that, and I think Nikki can speak to this, and we had a session this morning with the Metro mayors, with Sadiq and Andy Burnham and all the 9 Metro mayors, where they were really praising the work of the NHS on Q-COVID, which actually has brought in a whole cohort of people based on a number of factors, including age, but also ethnicity and deprivation, into cohort 6, massive cohort, about 7 million people approximately in that cohort. And of course, cohort 4, which is the clinically extremely vulnerable. And then of course, anyone over the age of 50. So the JCVI looked at this and they came down very clearly on the side of the 1 to 9, which is age-based, which is 16 to 64-year-olds with underlying health conditions, plus.
Oh no, I think we've lost him again. But I think we got the point really, which is
Done an interim report on this, but again, they want to go down by age, but slightly wider bands. So the under 40s will be by 10-year bands.
No, thank you for that. We lost you halfway through, but I think we really did hear what you were saying. So thank you so much for that, David.
Thank you. I suppose more questions are coming in on concerns about European countries, blood clots, and we can't get away from it. And the messaging is going to continue in the press when people leave this room. Dr. Nikki Kanani, what would you say around that whole piece around the vaccine? And there's something about why can't we get a choice of vaccine? So if that is the case with AstraZeneca, why can't we get choice? Is there choice?
I know it's strange in a sense, isn't it? Because actually, as we work in the health service, many of us talk about shared decision making and patient choice as being kind of really core tenets of what we do. But actually, we are in a position where we are still guided by supply, actually, relatively supply rationed. And so the government has done an incredible job securing a lot of vaccine. I mean, we're talking about millions and millions of doses, but we can't control when and in what order those vaccines come in. So it's really important that we support individuals, both healthcare professionals giving the vaccine, but also people receiving the vaccine, to feel confident that whichever vaccine they get offered is the right vaccine for them, and we support them to take up whatever vaccine is available. Because actually, and we're finding this a little bit now, if people are anxious about the Oxford AstraZeneca vaccine and say they'll wait, they might end up waiting weeks or months even, and you can't be in that position, because as we've all been saying, the vaccine saves lives, your life, those around you. So it's really important that when you're offered the vaccine, you take it up. So this is not a choice issue. This is how do we support people to feel confident about taking up whichever vaccine they're offered at the time that they're offered it, because actually they're both incredibly powerful and effective vaccines, both incredibly safe vaccines, and it's exactly right that we offer the vaccines as they come into the country, as they're approved and as they're accessible.
Okay, thank you very much for that. We're near to the close of this. I'm just going to ask Maurice McLeod, who is from Race on the Agenda, the Chief Executive, just to make a couple of points, Maurice. Then if you could pass back to Yvonne and then myself, and then we'll close down. So thanks very much for all of the questions and contributions so far. So Maurice, just a quick summary, then pass to Yvonne, and then over to me to close. Thank you. You're on mute, Maurice.
Sorry, I wasn't able to unmute. Hello, everyone. I just want to, here to represent ROTA, who are part of the Secretariat for CORE, I just wanted to say thank you to all the medical experts who've come together, for the Minister, for Professor Fenton. One of the things about our communities, and I say communities, is that when you come from either migrant populations or recently migrant populations, you understand the value of coming together, you understand the value of community, and that's what this is. That's how we have got through COVID, is by looking out for each other, and that's what this event is about. This has been put on by CORE, the Coalition of Race Equality organisations, where various organisations from all across the country have come together and said, we need to do stuff for our communities. That's how we are going to get the message out about vaccines, and that's how we're going to look after each other afterwards in whatever problems we've got coming down the line. So I just want to say thank you so much for all of your time, to the doctors, and for all the people who've turned up and asked questions. It's asking questions and treating people with respect and answering honestly that will get us through this. So again, thank you very much.
Thank you for that, Maurice. And just from me to thank all of the panel members. I've known many of you for a long time, and I have every confidence in what you're doing and how you're going about doing it. To our clinical colleagues who were on earlier, I am in awe of all of you. Your knowledge, your commitment, your professionalism is off the scale, and it has been an absolute pleasure and joy for me to hear you tonight, and it fills me with confidence to know that you are there. And to the Minister, thank you for all that you're doing and continue to do around this agenda. I think that we are going to have to do exactly what Kevin says, which is to keep our shoulder to the wheel, to make sure that we keep pushing against that door of equality, and to help with closing the gap on health inequalities, and of which this is a part. So thank you all. Thanks to everybody, and over to you, David.
Okay, and thanks to you, Yvonne. It's been great working with you. We met many years ago, and you've kept on the real fight in terms of issues around health inequalities. I'd like to say thank you to all the audience for being here, for contributing to the conversation, and to really holding to account the Minister and our esteemed guests who do such sterling work, but actually their work is affected better when they're listening to the contributions and the views that you're putting forward. If we had more time, there's so many other issues that we could have focused on. So, you know, the Gypsy Roma traveller community, where issues around the uptake there and not being counted is something that's has come up. It's such a key issue, this whole piece around vaccine take-up. And so thank you all very much for being here. Again, thank you for the guests. And on behalf of CORE, the Coalition of Race Equality Organisations, thank you. We'll be continuing with this. Thank you to Khan for the sterling work, also ROTA, Voice4Change, that you've engaged with in terms of ensuring this event could happen. So good night, and thank you all very much, and stay safe.
Yeah, good night. Stay safe, everyone.
As a
Bye-bye.
faith leader, my message is simple. Be aware of false information about the coronavirus vaccine. Be sure before you share.
As a faith leader, my message is simple. Be aware of false information and check information before you share. Check before you share.
I want to help you spot false information online and stop its spread. There are 3 simple tips. Look closely. Does the information seem trustworthy? Check. Is it coming from an expert? Still unsure if it's true? Don't share it. Check before you share.
Quick debrief. Right out of the way.